talk tonight is update on advances in the management of liver cancers, an interactive case-based discussion. There's been a few publications that have come out since we ran this program last year, notably in December, and be curious to see how Dr. Saab incorporates those into the overall discussion. So, Tony, with that, I'll go ahead and let you begin.
Yeah, no, thank you. Great to see all good faces, and so we'll go through this. We'll go through a case and then call it a day, hopefully within the next 40 plus minutes. So there has been finally change with the BCLC algorithm, which mostly integrated the systemic treatment piece for advanced stage C. This is based off our European colleagues, so the thought process is a little bit different than our crowded NCCN guidelines. But for first line, it's atezobev or durvalumab. We'll talk about this. If not feasible, sorafenib or lenvatinib, or even the integrated, interestingly, single agent durva as one potential option for those patients. And we'll talk about this. So that's not too far off from how we would think about it here. And second line, post sorafenib, the usual options. Now, post atezobev or durvalumab, and interestingly, in the US, the lenvatinib practice picked up, right, and assumed that, post-lenva is post-sorafenib, but the BCLC algorithm does not integrate this, given that there are no studies post-lenvatinib or durvalumab in that sense, and so clinical trials are encouraged. But in the US, perhaps a little bit differently, and then third line cabozantinib. Now, as we recall, there's been quite a bit of changes over the last few years in a disease that actually had no standards whatsoever, and now is pretty much riddled with a lot of standards, albeit a lot of them are Me Too or Me 3. So we've moved the needle a little bit in some, quite a bit in others, but still a lot of unanswered questions. So we started with sorafenib, then lenvatinib, not inferior to sorafenib, a little bit more favorable toxicity profile, displaced sorafenib for many patients, then disappointments with nivolumab, single agent versus sorafenib, ultimately got replaced. And we had atezolizumab, bevacizumab, with IMbrave 150, which came as a very positive study versus sorafenib, became our standard of care for patients in first line HCC for those eligible for IO after the disappointments with nivolumab. And when we look at the responses to immune checkpoint inhibitor-based therapies, you can clearly see that with single agents, your response rate is close to 10-ish%. When you start compounding, adding to your immune checkpoint inhibitors with the VEGF inhibitors, response rate is now over 30%. With the dual ICIs with CTLA-4 inhibitors, it's a little bit of a mixed picture, 10 to 30% of a response rate. So a lot of promises there. Now, the failures of nivolumab to pull ahead of sorafenib, certainly, and this is prior to all this other work that we're going to be talking about, push the idea of smart combinations to overcome mechanisms of resistance. And one of those is to combine anti-VEGF therapies like TKIs and bevacizumab to IO to enhance essentially the microenvironment, make it more immune competent, and also help those immune cells migrate into the tumor, so enhancing the activity of PD-1. So based on some preclinical data and some, good clinical early data, this study was designed IMbrave 150, which essentially randomized patients to atezobev versus sorafenib. And this study essentially was was randomized 2-to-1. The patients here had to have an upper endoscopy within 6 months prior to enrolling on the study. Now, having varices was not an exclusionary criteria. Having grade 1 varices was accepted, grade 2 and above if they were treated and no evidence of bleeding. So it was done mostly preemptively to make sure that, more at high risk varices were addressed before the patients were entered into the study. And this study was positive on all its primary endpoints. Survival was positive, 19-month versus 13-month. So highest at the time reported overall survival. And you can see superior to sorafenib with a hazard ratio of 0.66. You can see that tail continues beyond 2 years. PFS the same. Again, an improvement at the median and a hazard ratio of 0.65. And again, statistically significant. So positive on these 2 endpoints. And then the response rate was updated. And you can see if you apply the modified RECIST, you're talking about a third of the patients who have responded. I think the most interesting aspect of all this is, and we see this in clinic, is that patients who are exposed to atezobev actually can experience a complete response, something that we haven't really seen much of in patients with HCC until now. So about 10%, so 1 out of 10 patients will end up with a meaningful complete response, which ultimately ends up being durable. I mean, the duration of response is about 18 months with atezobev. And the safety did appear to favor atezobev, other than the typical bev-related toxicities and IREs, which are relatively controlled. You can see that the systemic toxicities of sorafenib are certainly some of the drivers of bad, like diarrhea, PPE, decreased appetite, etc. So certainly more on the sorafenib side. And that appears to have translated for atezobev for a significant improvement in the quality of life, a median of 11.2 months versus 3.6 months with sorafenib, and a hazard ratio of 0.63, which was statistically significant. You can see that this quality of life has been maintained beyond a year. So pretty positive. This study improved survival, PFS, improved response rate, better toxicities, and then better quality of life with atezobev versus sorafenib. Now, to continue on the discussion of of VEGF inhibitors, now moving to TKIs, plus minus atezolizumab versus sorafenib in advanced HCC. So you can see here the patients with HCC were randomized in Cosmic 312 to Cabo atezo versus sorafenib versus Cabo, with primary endpoints of PFS and OS, so 2 co-primary endpoints, and secondary endpoints were focusing on Cabo, cabozantinib versus sorafenib. This was a large study, met its primary endpoint of PFS, 6.8 versus 4.2 with a hazard ratio of 0.63, so that was positive. But the unfortunate finding was that overall survival was negative. Cabozantinib plus atezolizumab versus sorafenib was negative. You can see the survival of sorafenib was 15.5 months, and Cabo atezo 15.4, so not much of a difference. So the company decided not to pursue that further, understandably, since the survival is not much change between the two. And you can see the response rate was actually a bit disappointing. It was about 11% for patients receiving Cabo atezo. And the safety certainly does suggest that, one, you see more toxicities with Cabo atezo than with sorafenib, which again is not unexpected for these oral TKIs plus immune checkpoint inhibitors. LEAP-002 was highly anticipated studies, and LEAP-002 was a study that looked at lenvatinib plus pembrolizumab versus lenvatinib plus placebo. And again, phase 1b data looked pretty interesting and led to this phase 3 study. The anticipation was this is likely to be a positive study because of the design, primary endpoints of PFS and OS, secondary endpoints, response rate, etc. A large study, and this study unfortunately reported out to be negative. Now, it's interesting when you look at the Lenva Pembro versus Lenva had a reported survival of 19 months versus 21.2 months with Lenva Pembro, and a hazard ratio, an interesting hazard ratio of 0.84. So essentially, pembrolizumab did not seem to add much value when added to lenvatinib. The question, of course, is, I mean, these are pretty high survivals that were reported, including with lenvatinib. A caveat with the study is it's a highly selected patient population that was included in this study. Patients were required to have now an EGD within 3 months of entry, not 6, but 3. And the other thing about the study is that they excluded patients with main portal venous thrombosis, which is something that IMbrave 150 did not do. These patients tend to actually be bleeders, meaning those at higher risk of bleeding, but also VP4 ends up being a worse prognostic subgroup of patients. So by excluding patients with the worst outcome, the study tended to favor essentially patients with a much, much better prognosis than most of the studies in this space. That may explain the high survival with lenvatinib. And this is the response. So the response rate for the study by 1.1 was 26% for Lenva Pembro and 17% for lenvatinib. With the modified RECIST, this was a little bit higher, and duration of response of 16 months. So, I mean, you know, within where you would expect either to be. Now, the other strategy to enhance the activity of immune therapy is to add another IO, another immune agent, specifically CTLA-4, but there are others as well, and that's to enhance the intrinsic activity, and so to double up on immune checkpoint inhibitors. And based on that paradigm and some essentially early studies suggestive of a promising outcome, this study Himalaya was designed as an open label multi-center huge study. 1,300 patients were included or planned to be included. And these patients were essentially your typical patients that would enter into such study, but 2 main points to be made. One is, again, they included main portal venous thrombosis. So they excluded patients with a worse prognostic outcome, those with VP4 or main portal vein thrombosis. The other thing is the study did not require an EGD at entry. Unlike IMbrave 150 and LEAP 002, they did not require an EGD. Now, we got to be careful. The fact that they did not require an EGD doesn't mean that an EGD was not done. It just wasn't required. I always find it interesting when they put it in the criteria that EGT was not required, but they've never captured actually the data on EGDs or prior EGDs. So going back to this main trunk VP4 or VP4 thrombosis exclusion, now we've seen it in 2 studies, LEAP 002 with Lenva Pembro and Himalaya. You know, it's in some ways specifically for this study where a single use of tremelimumab, a CTLA-4 inhibitor at a high dose plus a PD-L1 inhibitor would have been an interesting regimen to examine in patients with a higher risk of bleeding. But those patients with a higher risk of bleeding are those that are likely to have a VP4 thrombosis, and these were excluded from the study. So unfortunately, for us, this makes it very difficult to understand the value of this regimen in this disease, especially with a PFS, a secondary endpoint, that was negative. In fact, if anything, it was a little bit worse than sorafenib at the median, although the hazard ratio was 0.9, but it was negative for PFS. The survival, the primary endpoint of the study, was positive with a hazard ratio of 0.78, and the differential was 16.4 versus 13.8 month. And this was statistically significant. So the study was positive and essentially led to the approval of this regimen. T300, single dose plus Durva, so STRIDE regimen, was positive. I think the more interesting aspect of the study, single agent Durva was found to be non-inferior to sorafenib, which is very similar to Nivo versus sorafenib, maybe a little bit better historically. Now, this did not lead to an FDA approval, but as you can see on the BCLC guidelines and NCCN, this would be considered as an option with a lower level of evidence. The response rates were not impressive. It was 20% for the STRIDE regimen. And another study, Checkmate 9DW, essentially Nivo plus Ipi versus sorafenib or lenvatinib as first-line treatment for advanced HCC, still ongoing. This is comparing Nivo Ipi to sorafenib or lenvatinib and primary endpoint of overall survival. This actually looks at the more aggressive, so low dose Nivo, high dose Ipi, so a little bit more toxicity expected here. I will see. This may be another option for our patients if positive, but waiting on this now. Whether it's going to be applicable or not will depend on a lot of other factors. Now, when looking at all the studies that were technically positive, at least for one endpoint in HCC, so IMbrave 150, Himalaya, and Cosmic 312. Now, Cosmic 312, although was negative for survival, was positive for PFS. So technically it was positive, but realistically, it's not something that one would consider as an option because the survival was negative. And this is one of the reasons why it never made it to the FDA. Himalaya was positive for survival, but was negative for PFS. IMbrave 150 was actually positive for all its endpoints. When we look at the response rate, again, it varies. I want to bring to your attention the lowest part, mostly the one discussing the toxicities. And you can see that essentially, as you would expect, immune-related events that requiring intervention were almost double with Himalaya versus IMbrave 150. When it comes to the bleeding events, and I want to focus on the grade 3 to 4 bleeding events, you can see that there's certainly more of them in atezobev in IMbrave 150 versus Himalaya. But one point that needs attention is the fact that sorafenib in IMbrave 150 had 6% of these events versus only 1.6% in Himalaya. And the main reason for this is the fact that with Himalaya, patients with the highest risk for bleeding, those with main venous thrombosis, portal vein thrombosis, so VP4, were excluded. And that explains essentially why sorafenib appears to be inducing less bleeding event on Himalaya versus IMbrave 150. And, again, to emphasize the fact that it was pretty unfortunate that this particular study, which would have been very useful for those patients who have the highest risk for bleeding, ended up excluding those same patients. So when we look at our treatment paradigm right now, patients with advanced HCC in first line, the majority of the patients with Child-Pugh A, and I would argue for Child-Pugh B7 with favorable performance status, would go for atezobev. For those who have a contraindication to IO therapy, let's say a patient with solid organ transplant or severe autoimmune disease, it's lenvatinib or sorafenib as their first option. For those who have a risk of severe bleeding, and again, I'm not even sure who those patients are. Those tend to be either those patients with uncontrolled varices, so that have main portal venous thrombosis, therefore they were excluded from the STRIDE regimen. But that one patient in 100 perhaps would be a good STRIDE candidate. I'd say for those patients with a poor performance status and Child-Pugh B score 7 or Child-Pugh B8, I may consider actually durvalumab as one option, although I wouldn't go beyond Child-Pugh B8. And then, for second line, we have a number of agents available to us, but those that make the most sense are cabozantinib or regorafenib, perhaps lenvatinib, post-atezobev today. Ramucirumab, I'm not sure has much of a role. Lenvatinib is more of a VEGF inhibitor than a dirty TKI and may not make as much sense for patients with HCC that progress on atezobev, and we've published this about a couple of years ago, which suggested essentially that the best options for these patients in second line would be either regorafenib or cabozantinib. So, in summary, atezobev seems to be the primary standard of care. Maybe for the occasional patient, Tremi, Durva may be applicable. For patients who may not be eligible for IO, then sorafenib, lenvatinib in first line. Second line options would favor cabo or rego. Other options would be the other offenders. Child-Pugh B score HCC remains a challenge. We don't have a lot of data there. And, we're moving a lot of these therapies into earlier stages and neoadjuvant studies. So I'm going to stop here and move to the cases. Any questions first?
Tony, let me just ask a quick question. It's a lot of patients with the HCC, and I, just wonder if you could give a quick answer to where in the world, I don't say that's, cynically, but where were most of these studies done? I assume in Asia?
So it depends. Cosmic 312 actually had many Asian countries, primarily US and Europe, actually no China, which is potentially one of the reasons why the study was not as positive, because those patients with hepatitis B tend to do better on IO. IMbrave 150 was more balanced. There were, representations from across the globe. Himalaya, the same. And they do have a China-only cohort that continues to be analyzed as well. So, I'd say about 30-40% of those patients came from the Western world. But I think your question is alluding to, like, do we even see those patients here at the level and rate? And the answer is yes, to a certain level, but these studies cannot and would have never accrued or completed if they were run just out of the Western part of the world. All right, well, let's go to a case. Who's presenting this one?
I think this is Dr. Wu.
Okay.
Yeah.
Yeah, hi.
Yeah.
How are you?
Hi. How are you?
Good, thank you.
Okay, good to be here. So I have a 60-year-old man. He had hepatitis C related HCC, child A. Could not tolerate sorafenib after 3 months, progressed actually pretty quickly, and then went on a study as a non-immune therapy for quite a while, 3 years. And then he progressed. So I gave him Nivo for 2 years. He progressed. He was on Cabo for 6 months, progressed quickly. So I started to len. So, I saw him pretty much yesterday, and I see the markers going up. I'm gonna do a scan. So I wonder what I do next. What would you recommend? He's never seen atezobev, although he's seen Nivo single agent. Never seen durva-tremi. Is there a choice, something you would prefer, or anything else beyond those two?
Yeah, that's interesting. So you have one other option, and that's regorafenib, which I probably wouldn't favor ahead of atezobev or durva-tremi, or I would even argue Nivo-Ipi could be also considered in this case. But really nice response to Nivo. That essentially, tells me that his disease is pretty immune competent, and so I'm actually if I would want to recommend anything for this patient is to go back to IO plus another agent, so plus a combination. And the other thing that's interesting in this patient is you can see, nice response with Lemva and Cabo. I mean, these are longer than expected responses. This is a patient I probably would go to Atezo-Bev if his insurance would allow it. And I would expect actually he'd have a nice response to Atezo-Bev. If for whatever reason the insurance does not bounce out, I would consider Ipi/Nivo, which technically is approved for refractory disease post-sorafenib. Now, granted that this patient has seen Nivo, and you can argue that in some other disease settings, Ipi/Nivo has shown some responses in those who may have had some relative benefit from Nivo. So I would say that, if you can go for Atezo-Bev, that'd be ideal because, his disease seems to independently respond nicely to IO and then to VEGF inhibitors. So it'd be nice to see when you combine the two, if you can pull a nicer response. Otherwise, I'd go to Ipi/Nivo perhaps.
Thank you. Super helpful. Thank you.
Yeah. Keep us updated. I mean, it's a very interesting case. All right. Okay, Dr. Smith.
And he moved to the 7:30 call.
Okay,
But
got it.
let's go ahead and just run through it anyway.
Okay.
I'm gonna, Dr. Saab, I'm gonna ask
Yes.
at least two questions if you don't mind.
Yeah, please.
One is that, I mean, I don't have that many patients with who had who had single agent IO, but let's say if I have a patient supposedly with B7 or B8 who was started on single agent IO, and then if their numbers improve and they are going in the child A category, would you add at that time another agent, a second IO or BEV, or would you just keep them on the same if they're responding?
Well, personally, I probably would keep them on the same and wait. And when they progress, I'd add another agent rather than do it from the get-go. Now, unless you feel that the response is, not as strong as you'd like it to be, then you could justify adding another agent to it.
Okay. And then I'm looking at your last two slides where you had a conclusion.
The Child-Pugh B patients.
Where you mentioned your preferable first line treatment. So you said with child A, Atezo-Bev, why not Ipi/Nivo if there is no contraindication, or how do you choose? Like,
Oops, let's go back to this one.
yes, Atezo and Bev.
Yeah. So Ipi/Nivo, does not have an approval in first line yet. It's waiting on the results of 9DW. It's not unreasonable, if the study is positive, to put it in the mix. So for those patients who have, a solid performance status and Child-Pugh score, I think Atezo-Bev has the best data at this point of time. The STRIDE regimen, Durva/Tremi, positive on OS, negative on PFS, excluded patients who are not the typical patients, who are the typical patients we see. Most patients will have some level of portal venous thrombosis, makes it less attractive overall. So I think that's why I'd say Atezo-Bev would be your preferred option, pending 9DW results and seeing, how this will dissect out.
Okay, makes sense.
Yeah, and the one caveat I would tell you though, the Ipi/Nivo, the way it's being developed in HCC is different than the way it's being developed in colorectal cancer. They're using the higher dose of Ipi and the lower dose of Nivo based on the phase 2 randomized study. The problem with this is that the toxicities are pretty rough, specifically the liver toxicities, which, in this group of patients, that's the last thing you want to see. And so we'll see. It'll be interesting to see how this checkmate study ends up ends up specifically from the toxicity standpoint. I don't want to make guess games, but I mean, I'd be surprised if it's not positive. But how positive, and whether the toxicities will be acceptable for the level or magnitude of benefit will be something to watch for. So this is this one, which is still pending.
So I actually meant not Ipinevo, it's the same group, but I was actually talking about Himalaya, where that is.
Oh, Himalaya. So Durva-Tremi, got you.
That is approved. I don't remember that.
It is approved. So Durva-Tremi is approved. The problem with this particular study is that it was positive for OS, but was negative for PFS, and the response rate was not that significant. The toxicities were relatively acceptable, mostly because they used only one dose of durvalumab. Of tremelimumab. So just single dose Tremi. My problem with this study personally is that one, it was negative on one its endpoints, which is PFS. The second is it did exclude patients actually with portal venous thrombosis, main portal venous thrombosis, which is a large group of patients we see in clinic, but also those are the patients who actually end up with a risk for bleeding because of varices. So I'm not that impressed, with the results of the study per se, and they missed on one of the endpoints. And that's why I tend to favor it less. I'm not saying it's not a reasonable option. It's not a favored option.
Yeah, I would say it depends whom you ask. So you are in Mayo. If I ask MSK guys, they would have a different opinion.
Yeah, because there's because of their bias to the study. But interestingly, I can tell you, because I see some of their patients here, atezo-bev remains their main first-line treatment. At least a lot of the patients that come and roost in the winter down in Arizona that I've treated were mostly on atezo-bev. So take it with a grain of salt.
Right.
I'm curious, Tony, what percent of patients do you think get Durva-Tremi first line?
I think that you're going to see more patients getting Durva than Durva-Tremi in the first line, because Durva-Tremi and Durva, if I go back to the, let's see, to this, you can see the responses are very similar. And the survival is actually pretty similar between Durva-Tremi and Durva. But anyways, I'd say that, for Durva-Tremi in our practice is, at Mayo overall and across all our practices, 3 practices, is a rare event. You see use of Durva in those patients with a higher Child-Pugh score, B7 plus, with a less than ideal performance status. We've gone for single agent Durva. So Tremi Durva is actually almost never used, because I don't see frankly, I don't see a major advantage for it. I do like the data with Durva because it gives me a leeway in those patients where I'm not going to go with a combination IO.
And if you get into the hepatotoxicity with IOs, what do you do?
Yeah, which, as you know, is worse with CTLA-4 plus PD-1 or PD-L1. Depending, of course, you stop the drug. If it's grade 2 plus, we initiate steroids, and if it's severe enough, we're discontinuing the IOs altogether.
Oh, you don't go to the and other factors, the anti-TNF and other stuff.
Oh yeah. I'm sorry. You follow the regular algorithm, infliximab and others, yes. Okay. For severe hepatitis, yes.
Okay, got it.
And you're going to see more of it as you start combining these checkpoint inhibitors, especially in this patient population.
Right, that's would be the biggest worry. How would you know that this is, especially when they are in the beginning of the treatment, is if this is a toxicity?
It's a little it can be quite challenging, but if
You
it's
have to
if
go
it's
for the scans very quickly and insurance approvals and all those kind of stuff. Yeah.
yeah, you do have to you follow. I mean, I would if it's abrupt, if it's within the first 2 to 3 months of treatment, and there are no other signs of disease progression, I would just very quickly move to treat those patients as hepatitis, as immune hepatitis.
Okay.
Okay, does anybody else have any questions or comments they'd like to share? If not, we will go ahead and close up shop for the evening, and I'll thank
All right.
everybody for taking some time and joining us for the discussion tonight.
All right. Let's see you guys. Take care. Bye-bye.